Dear colleagues, I would like to greet you. My name is Nunay Azarian, and I'm representing an Armenian association. I'm representing Armenia Eye Care Project Charitable Foundation. As we're starting our next ground round, and today it is dedicated to the retina diseases, as usually. And today we have organized this meeting today with Armenian Eye Care Project Charitable Foundation, Malan Ophthalmological Center, and the Department of Ophthalmology of Yerevan State Medical University. Today's we have very respectful guests, and our session will be led by our Armenian and international colleagues. From Armenian side, there will be Armen Vartanyan, who is a doctor of medical sciences, professor. He is a lecturer at the Department of Ophthalmology at Yerevan State Medical University. He is the president of Armenian Ophthalmologists Association. He is the head of vitro-retinal department at the Malayan Ophthalmological Center, and he's an AECP fellow. If I'm not mistaken, he was first AECP fellow. From American side, there will be Baruch Cooperman from USA. He's a PhD in technical scientist. He is the director of the Gavi and Herbert Eye Institute and UCI School of Medicine, University of Toronto, Irvine. He is also a dean, and he is a professor at and also today we have Carmen Bailen, Research Science Department of Ophthalmology and Vision Sciences, University of Toronto, retinal surgeon. It is very good. Today also with us is John Hovanesyan. He is from California, United States, and he's representing an surgical association of Armenia. And he's a member of, he's representing a California university. He's a professor also. And today we have Carmen Balian with us. She will represent the clinical case. She's a research scientist at the Department of Ophthalmology and Vision Sciences, University of Toronto. And I can tell you that she has joined the Armenian medical mission, and I would like to represent you that their credit will be received by the participants who will total participate all the program, and they will fill in the pretest and the protest. And I'm sure that these presentations will be very interesting and important. And I would like to remind you that you can send all your questions via Zoom platform. And so let's start. And so I would like to ask you that please ask all your questions. And for today's participants will represent them. And so they will represent the questions. So the first question, uh, which of the following is not a major clinical criteria for diagnosing Irvan syndrome, retinal vasculitis, arterial aneurysms, neuroretinitis, and macular exudates? Second question, why anti-VEGF was injected in the left eye? First option, because of the macular edema, because of there is a cataract progression, there is a neovascularization of the optic discs, and there was an increasing in intraocular blood pressure. Why it was planned to do the to perform the quantiferon gold testing planned to confirm bacterial conjunctivitis, to allow the tuberculosis-associated uveitis since systemic workups were negative, to diagnose sarcoidosis, to check for HIV co-infection. Fourth question, which mechanism best explains the ischemic retinopathy in patients with preeclampsia, retinal arterial vasospasm, and endothelial dysfunction? Increased aqueous humor production, enhanced retinal photoreceptor regeneration. Which clinical finding is the most associated with ischemic retinopathy in preeclampsia? Cotton wool spots, blood in the vitreous, and the retina extra damage. Which is the primary ophthalmologic concern in severe preeclampsia? Reduced retinal blood flow causing ischemia, increased intraocular pressure, accelerated cataract formation. Which of the following fundus features is the most characteristic to the West Nile virus retinopathy? Circular parfoveal drusen, linear or curvilinear clusters of hypopigmented chorioretinal lesions following the retinal nerve fiber layer, peripapillar supraretinal hemorrhage, and bull's eye maculopathy. Which ocular complication is most frequently associated with the West Nile retinopathy? Serous retinal detachment, vitreous or anterior uveitis, macular hole, choroidal neovascularization. West Nile retinopathy is most strongly associated with which systemic condition? Chronic renal disease, immunodeficiency or advanced stage, diabetes mellitus, or autoimmune thyroid diseases. First of all, I would like to greet my dearest colleagues from United States and Canada. I would like to greet uh, my very respected Barry Cooperman, uh, who is one of the leading specialists in the field, and I'm very glad that today we will have this pleasure to listen to his opinion and his approaches, whereby the topics which will be represented by us. And I would like to greet, of course, John Hovanesian from California, who is for the first day on this beginning and for many decades he's participating in this project, and he's participating till now, and we have very good relations, and he's very important person for us. I would like to also greet to Carmen Balian from Canada and Ping Yan from Canada for their very interesting presentations. Carmen will represent a very interesting case. It will be very interesting for us to listen to this case. And we, of course, will discuss the approaches from also Dr. Peng Yang. And now I would like to represent the case report presenters. The first presentation, I would like to start with Carmen Balian, and the topic will be the West Nile retinopathy as one of the dangers in ophthalmology. Please, Carmen, floor is yours.
Okay, thank you. So let's dive into our first case. We have a 61-year-old female, and they were sent in for a consultation for retinochoroidal lesions in both eyes. They were complaining of vertigo for 1 month, fever, nausea, loose stools, tearing, photophobia, and 1 week of floaters in both eyes. Can I advance? Okay. So on examination, their visual was pretty good. They had 20/30 in the right eye, 20/25 in the left eye. Slit lamp examinations showed AC of +1 cells in both eyes and mild cataract in both eyes again. So on fundus photo, we have vitreous opacity, which indicates that there's vitritis in both eyes. And looking more closely, we see that there's these white punched out chorioretinal lesions. On autofluorescence, these lesions are more prominent and they lie along the nerve fiber layer. On IVFA, in the early stages here, we see in the left eye, we can see a vascular leak, and in the rest of the images in the late stages show a string of pearls. So our second case, we have a 68-year-old female followed with anti-VEGF treatment for diabetic macular edema. They have a past history of breast cancer, and currently they are in remission. They've had chemo and radiation. So the patient was hospitalized with generalized fatigue and weakness, and it was thought that this was due to the cancer remission. They had no visual symptoms to report. Okay, visual acuity was 20/40 in the right eye, 20/30 in the left eye. IOPs was 19 and 15. Slit lamp examinations showed a quiet anterior chamber in both eyes and +2 cataracts. So we here can see that the patient had no visual complaints, but the fundus exam shows lesions. First, we thought that these lesions were due to laser PRPs, but they were of different sizes. Now, this was seen in both eyes, and they, when you look at the lesions, they are round and they're well demarcated, chorioretinal punched out lesions, and there's more temporally than nasally. Okay, so on autofluorescence, these again, the lesions are well demarcated, and there's a hyper autofluorescence centrally and with a round ring of hypoautofluorescence peripherally. And we did ERG testing, both multifocal and full field were normal under both photopic and scotopic conditions. So for the diagnosis, we did a complete uveitis workup, which was negative. And for we had similar cases throughout in a very short period of time, in about 6 weeks, a handful of patients showing up with these findings. And what we did is we thought, okay, let's test for West Nile virus, and that came out as positive for the IgM test. And so I'm going to pass it over to Dr. Yan, who's going to talk about West Nile retinopathy.
I'm Dr. Yan from Toronto, Canada. I'm a vitreoretinal surgeon. So why is a vitreoretinal surgeon presenting West Nile retinopathy? It was just because over the past 2 months, we saw a whole bunch of patients who presented in my clinic with these conditions. Some are my patients with diabetes and came in with these lesions, these targetoid lesions. At first, I was puzzled because I thought, well, I never done PRP for these patients. And looking at closely, you realize these are not PRP lesions, right? These are actually pathognomonic for a disease that we're going to look into. A review of this virus is a flaviviridae and cousins of yellow fever, dengue fever, St. Louis encephalitis, a single-stranded RNA and transmitted by mosquitoes. And in the nature, it is cycled between bird and mosquito. So the best vectors to carry the disease around the world without borders, they don't need passport, they can fly, and migratory birds can travel everywhere. And similarly, we're seeing a lot of mosquitoes moving around, and they will affect horses and humans by accident because we're the actually dead end hosts. However, we can still transmit disease through transfusion, organ transplantation, and sometimes breast milk. The disease was first discovered in 1937 Uganda in the West Nile district, hence the very novel name, West Nile virus. And then since then, there was outbreak in Europe, North Africa, and in 1999, it made its way to New York City, and there was an outbreak of meningoencephalitis. And of course, being Canadians, we're the neighbors, and the virus knocked on our doors, and we welcomed them with open arms. So in 2002, we got our first cases, and now it's sort of endemic. However, it's not that bad in Canada until recently. So if this disease is not on your radar, you won't actually make the diagnosis. And that's why many patients were hospitalized. They have the slew of investigation, and until someone makes that call. And so if you're not in that region, you might not think of this disease. Hence, this presentation is to raise the awareness that the number is actually increasing. And so in the past few months, we saw a huge number of influx of this condition. And even for me, I'm seeing some of these cases now. So we need to be aware. And if you don't recognize it, if you don't think about it, you probably won't make the diagnosis. Majority of patients are asymptomatic. And if you get the disease, there's presumed that you might have lifelong immunity. 20 to 30% of patients will have flu-like symptoms like fever, headache, just like your general flu-like symptoms. Less than 1% will have neuroinvasive disease where it can lead to meningitis, encephalitis, poliomyelitis, which can lead to fatality. Although it's only less than 1%, 80% or more of all the reported cases are the neuroinvasive disease, because patients who are asymptomatic or with mild fever don't usually present to clinic. And if they do, they don't get tested. So keep in mind that, it's a majority of patients can just present as regular fevers, and only less than 1% present with neuroinvasive disease. This is a busy slide, just tells you the variant of presentation they can present with. The incubation period can be between 2 to 3 days to up to 2 weeks, and immunocompromised, it can be up to 21 days. The risk factors for neuroinvasive disease in these cases are usually in immunocompromised patients and patients who are advanced in age. Of course, if they have a history of cancer, diabetes, these are all sort of the comorbidities that can lead to the increase of their risk of neuroinvasive disease. Long-term sort of sequelae of this condition, many of my patients are complaining of fatigue. They feel down, and then they feel they're slow in terms of memory recall and so on. And so these can last for a long time. In terms of ocular findings, it's not common. However, in a recent study, it was found that for all patients with West Nile virus, there's about 24% of patients who will present with ocular findings. Within that 1% of neuroinvasive disease, about 80% of them will present with retinal findings or retinopathy or various uveitis presentations. And for the long-term ocular sequelae of it is that these chorioretinitis will eventually resolve. Vision usually restores, but they can result in permanent pigmented atrophic scars and result in field defect and vision loss, especially if macula is involved. And these scars can lead to corneal neovascularization, where anti-VEGF might be required. So the presentation triad is you can get these sort of typical multifocal chorioretinitis that presents in a fine circular white-yellow lesion that almost look like a little target lesion. They're deep, that affects the level of the RPE and choroid. Usually can range from 100 micron to up to like 1500 micron, but average about 200 to 500. They can get vitritis, anterior uveitis. They can get neuroretinitis, optic neuritis. So it just adds the list of differentials for neuroretinitis. So the pathognomonic feature of this condition, which makes it easier for us to diagnose, but again, it has to be in the background. You have to know that the condition exists. Is the targetoid lesions that look like a bullseye. Look at these little circular lesions. They almost look like the PRP spots, and it's got this sort of hypopigmented core with a hyperpigmented ring around it. The distribution is either scattered or they can be linear arrangement, usually in line with the path of a radial nerve fiber layer. And they're more commonly found temporally or supranasally. And this sort of is significant in terms of its distribution because it's suggested that it might be spread along from the CNS along optic nerve into through the nerve fiber layer and then affect the RPE and the choroid. The testing for it is IgM, IgG serum testing for enzyme immunoassay. 99% of samples are positive for IgM at 5 days of onset neuroinvasive disease. Although there are currently no real vaccinations available, but there are clinical trials that are ongoing. The route of entry is also interesting. You thought that hematogenous dissemination from blood during viremia, it gets into the CNS. And then from there, somehow contiguous spread from the optic nerve into the eye through the nerve fiber layer and then affect the RPEs. Ocular findings actually mirror systemic severity for neuroinvasive disease. The more severe symptoms they have, they might end up with more of these multifocal chorioretinitis spots. The virus replicates in the RPE cells, and that's why you will see a lot of the OCT changes, like disrupted of ellipsoid, and also these sort of little clumps where hyper sort of proliferative sort of appearance of the RPE cells. And so it's local replication inside the eye. So majority of the spots are the multifocal choroiditis, but you can also get retinal vasculitis, optic neuritis, vitritis, and other symptoms. IVFA is very important for all uveitic workup because it gives us idea of disease activity as well as complications. So like all white dot syndromes and other sort of uveitic conditions, it gives you the early hypo, light hyper. And the early hypo is because of the blockage from the infiltrative blockade, and then inflammatory infiltrative blockade, and then late staining of the diseased RPE and surrounding inflammatory leakage. and it gives you that sort of target like lesion. And on the OCT, what you can see is that you can see sort of this arrow points to the disruption of ellipsoid layer, and which is not pathognomonic. You can see this in many different disease, but also there is that RPE irregularity with this hyperreflective nodule over RPE. Perhaps that's like sort of damage from the viral replication. There's also this little sort of hyperreflective spot that you can see spanning from alternate nuclear layer to alternate platform layer. And all these findings will resolve and doesn't really leave marks on the OCT. They can resolve. So the journey of West Nile to Canada, here's the timeline, and I did a quick Google search. Armenia actually had an outbreak last year with over 108 cases that were reported. Remember, these diseases are underreported just because only the severe ones seek medical attention, right? And I'm not sure what the number is for this year, but just something to keep in mind that if you see patients who present with sort of viral illness and with these target lesions, you think about West Nile virus. There's no treatment for this, like many of the viral conditions. It's primarily supportive hydration, respiratory support. How do you differentiate this from the various sort of white dot syndromes and other infectious retinitis? It's pretty pathognomonic the way that it presents itself with these round lesions. It's different from arm because it's full thickness necrosis. And for toxo, you get this more dense vitritis that's over either old pigmented scar or these new retinal lesions. Of course, MCP, PIC can look similar, but again, because of this infectious nature, the other ones are idiopathic. The way that the distribution is also different. And so, you know, these lesions that we see are pathognomonic for this particular condition. Because we see this cluster of presentation in Toronto, and that's why I just want to make sure I bring this to attention and, you know, that we're all aware that this, you know, condition is going to spread, and we might see more of it next year, maybe in the summer and in the fall, usually between July to September. And prevention, of course, is key. Insect repellent and getting rid of standing waters. And mosquito usually feed in dusk and dawn, and then wear, you know, make sure skin are covered. If they're not covered, insect repellents. So the take-home message after all this discussion is, you know, did you have flu-like illness, neuroinvasive symptoms, the timing, the seasonal timing, the morphological features of the retinal lesions, and the distribution of them? Are they linear that runs along the retinal nerve fiber layer? So with this, you can pretty much make the sum diagnosis of West Nile retinopathy. Thanks to the team who puts this together for me, and these are my references. Thank you very much, everyone.
Thank you very much for a very, very interesting presentation. For us, it was a very, very new pathology. And we don't have these mosquitoes here in Armenia. But it was very, very interesting presentation, and it was very interesting to know about this. So the next presentation will be represented the third year clinical residents, Hasmi Gasparian, and there's a bilateral intermediate uveitis and retinal vasculitis, the clinical case. I would like to greet everyone, and today I would like to represent to your attention one clinical case. So the patient was female, 43 years old, and she was complaining of the blurring and decreased vision in both eyes, especially in the right eye, and also headache. In her anamnesis, she don't mention any systemic disease or any other smoking or alcohol. Clinical findings, visual accuracy 1, intraocular pressure within the normal range, and with anterior segments, there were no abnormalities diagnosed, and vitreous cavity, there was no inflammatory cells detected. As the fundus examination, there in the right eye there was an exudatus in the macula and epiretinal membrane, and there's a macroaneurysm, and there's an ischemic retina and ischemic in the left eye. There is an exudate in macula, and there is a neovascularization of optic nerve disc and peripheral retinal ischemia. With the OCT, we find out in both eyes vitreoretinal traction and hard exudates. So There was a branch retinal vein occlusion manifestation in both eyes, and the diagnosis was bilateral vasculitis. To explain this kind of a picture, we performed a few tests. There is a complete blood count, coagulation panel and clotting factors, HbA1c, lipid profile, glucose and urea, creatinine, as well as CRP, rheumatoid factors, HIV and syphilis antibodies, as well as in chest X-ray, ECG, and echocardiogram. The only abnormality which was finding there was there were coagulation markers, the prothrombin time and activated prothrombin time and thromboplastin index, which mentions that there is a decreasing in coagulation. She was referred to the hematologist consultation, which do not find any pathological findings. And there was also a neurologist a consultation was performed as well as MRI. No pathologies were diagnosed. And so we exclude the hematological, metabolic, rheumatological infections, immune, cardiovascular pathologies, which can explain the fundus picture, which we performed. And so for 1 month, the patient was lost. And when she came for the second time, there was no changes in the fundus. And so we performed the intraventral anti-VEGF injection because of the neurovascularization and to follow up the patient. So, and now let me please speak without one of our probable diagnosis, which is an idiopathic retinal vasculitis or of a known etiology, Irvan syndrome. It's a, which is a known etiology subtype of. And Irvan syndrome is going with the 5 stages. First one, there is a macroaneurysm, exudation, neuroretinitis, vasculitis. From the second stage, there's a capillary non-perfusion. In the third stage, there's a posterior segment neovascularization. And in the fourth stage, anterior segment neovascularization, and there's a neurovascular glaucoma. The Irvan syndrome diagnosis is based on the clinical symptoms and excluding the other symptoms. We should exclude immune, infection, and inflammatory reasons. So as well as the Irvan syndrome has a major and minor criteria, and there's a major retinal vasculitis, arterial macroaneurysm, and neuroretinitis. We also have the minor secondary criteria like peripheral capillary non-perfusion, neovascularization, and macular exudation. I would like to mention that the Irvan syndrome should be differentiated with the fundus vasculitis, like idiopathic retinal vasculitis, senile retinal arterial microaneurysm, Quats disease, and Ills disease. Now let's come back to our case. 20 days after, 2 days before our ground round, the patient came for his follow-up screening. And we have some neurovascularization, and there was an inflammation in both eyes. In the left, there was +1. So the diagnosis was bilateral and uveitis. And I would like to remind you what is the uveitis, which is an inflammatory disease in the eyes, which is including there's a painless floaters, blurred in vision, and snowball-like changes. In most percent of the cases, it is idiopathic. It is in less percent of cases, it is associated with some systemic diseases like sarcoidosis, multiple sclerosis, and tuberculosis. And in our patient, we excluded all the symptoms. And due to financial limitations, we did not the TB gold test. And in the future, we are planning to perform this test as well and to exclude the probable back-check disease. And also, of course, we should do the ongoing monitoring and observation. And I would like to mention that the vision is 1-0 accuracy, and that's why we do not perform the treatment. She's under our supervision. And thank you for your attention. Thank you for your presentation. The next presentation, by Avedisyan Susanna. The ophthalmological case reporting connection between preeclampsia and ischemic angioretinopathy. Good day, dear colleagues. And as it was mentioned, I will represent the clinical case and we will speak about the preeclampsia and ischemic angiopathy connection. So in the July, in the Sergei Malyan Ophthalmological Center, there was a admitted 25-year-old pregnant female. She was complaining of the worsening of her vision in both eyes, and primarily there was a 0.08, and in the right eye 0.09, and intraocular pressure was within the normal range. And the patient mentioned that it was a second pregnancy, and she was diagnosed preeclampsia, and she was performed an OCT in the eyes, both eyes, where we can see the subretinal edema. I'm sorry for the quality, but and also we did the fundus uh, photography test, and here we can assess the changes in the fundus, and you can see that there's an ischemia, a retinal ischemia, exudates, hemorrhage. There's a dilated and congestion in the veins, and narrows and kind of tortuous arterial arteries. And before the patient going to the detailed analysis and which procedures were performed, let's speak about a few mechanisms, how the preeclampsia we can reach to the ischemia. In ischemic angioretinopathy, one of the causes from pathophysiology is a systemic endothelial dysfunction. Next reason is might be severe vasoconstriction, and there's a breakdown of the blood-retina barrier, retinal ischemia, choroidal involvement in the process, and of course an acute hypertension component. And let's speak about this mechanism separately a little bit in a few words. As we know, the preeclampsia is characterized by widespread endothelial damage, which occurs due to a release of the anti-angiogenic factors from the placenta. The factors which are suppressing the angiogenesis. There's going to be oxidative stress, which leads to the immune dysregulation. And as a result, we have the endothelium the changes, and there's going to be vasoconstriction, and the endothelial dysfunction will lead to the retinal scapulaire, which are the most sensitive vascular structures in our body. The next reason will be a generalized vasoconstriction, which occurs due to increasing of endothelin 1 and thromboxane A2 really increasing, and as well as nitric oxide decreasing. And here the picture can be similar to the with a common hypertensive ischemic angioretinopathies, but as in our process, we also have the preeclampsia. The process is going more severe in the clinic and more rapid. And then let's speak a few words about endothelial dysfunction, which leads to the high pressure. There was a leakage of plasma into the retina, which in the fundus can increase the, and we can find out these hot spots. And of course, in a long-term arterial spasm plus endothelial dysfunction leads to the decreasing of the perfusion, which usually leads to a congestion, as I spoke previously, and will lead with the cotton wool spots. And there's an external retina hypoxia will lead to the visual disturbances and release of the VEGF factor increasing. Also, we should remember that in the process, we have the involvement of the choroidea, which lead to the chorioacapillary ischemia, and there will be a pigment epithelium case of this damage. For the first picture, we see these flashing spots, and from the second picture, it's increased streaks. And so, as in the preeclampsia, we have a long-term increasing of the blood pressure. We can visualize the papilla edema, phlegm hemorrhages, and there might be vessel tortuosity. And as in case of the preeclampsia, the ischemic angioretinopathy is more correlated with endothelial dysfunction. So in these cases, even the not that much increasing of the pressure can lead to the ischemia in the retina. And if we would like to be very short, let's see the mechanism. There is a preeclampsia, there is a systemic endothelial dysfunction, there's going to be acute vasoconstriction, and then there's going to be the breakdown of the blood-retina barrier and microvascular ischemia. And so coming back to our patient, this is the first pictures of the patient. And after this, we can see the future changes. This is the second picture for up left and right eyes, which was performed in September. Here we have the pictures of October and November. And so for those last 3 months, the patient 3 times was injected VEGF. And here we can compare the vision changes in these 3 months. And also we have the OCT picture. And so as in the conclusion final comparison for the first and the last pictures, where we see that the vision accuracy is 0.8 is reached to the 0.8, and from the left 0.09 it is reached to the 0.3. The patient is under our supervision, and we are waiting for the future improvement. So thank you for your attention. Thank you for your presentations, dear colleagues. And now let's start for the discussion of these clinical cases. And please, if you have any questions for the first presentation regarding the West Nile retinopathy as a new ophthalmological danger, any questions from this topic? And which will be the opinions, please? We would like to hear to your opinions as well.
Okay. Yes.
For your permission, I would like to ask a question to the presenter. Here we listened to the presentation and we saw this. It was very, very interesting. The very new disease for us, and we are not familiar with this disease. And this disease, which can lead to the very, very serious complications. And I would like to mention that there's nearly, it was mentioned that it was going to be around 1% of the meningoencephalitis. And I would like to understand the meningoencephalitis. It can appear as a result of the late treatment, or it has nothing common when you started the treatment. Or it is just a virus pathology which can lead to the, like in case of the anthrax.
It's the pathology of the virus. So so it can present as meningitis or encephalitis in different patients. Some patients also have acute poliomyelitis-like syndrome as well.
Okay.
So it is mostly associated with the virus. These complications are associated with the virus. And what about the percentage? As I don't know, maybe you don't see this more commonly. Uh, I would like to ask the question like, and non-deficiency patients, the percentage, is it higher in non-compromised, immunocompromised patients? Do you have any evidence-based data that in immunocompromised patients or any patients who have immunodeficiency like diabetes or other diseases, cancers, neoplastic disorders, the frequency of this disease, is it higher or not?
So, and they have a more severe form of the disease in patients who are immunocompromised or have history of cancer or diabetes.
Carmen, I have a question for you.
Yeah.
So again, this is an emerging threat in the United States and in Canada, but one
Yes.
that's been around for a long time that wasn't addressed, but I'm curious as to how much, because they both manifest with a spectrum of disorders, but ocular histoplasmosis, which is very common in the central United States. I assume it's the Ohio and Mississippi River valleys. I assume it's also common in Canada. How much of the manifestations is there an overlap? Because there's a triad for ocular histoplasmosis, but the punched out lesions that you describe are somewhat similar to histoplasmosis. Is there confusion in that diagnosis between those two, given that they both have an underlying infectious etiology?
That I don't know. Because it's an emerging condition that we have to keep a high suspicion of West Nile in our differential. So there is a lot of overlap with toxoplasmosis, the lesions being very similar. So we have to be more aware of West Nile retinopathy and keep it in our differential.
Well, Barry brought up something that occurred to me as well as I was listening to the really great presentation, Carmen and Peng. Thank you for doing it. Which is the similarity on initial quick presentation to ocular histoplasmosis, where you get these discrete lesions, peripherally. And many of us see patients who've had past histoplasmosis with the characteristic findings of the punched out lesions, clear vitreous, and they can get macular lesions as well. But would tend to dismiss this as being related to that fungal disease. And I guess my message, I'm not a retina person, but my message is that everybody on the call, whether you're a retina specialist or not, needs to have a level of suspicion when you see lesions that either weren't there before or look funny like this. Don't write off, the oddball West Nile virus, even in Armenia. So.
Agree, John. And I would add that one of the things that helps differentiate West Nile virus presentation, again, there's a spectrum of presentation and with a lot of overlap. But what we tend to see with West Nile virus, as rare as it is, and we don't tend to see with histoplasmosis, is that chain of pearls effect along the arcade. And that, again, you don't always see that also with West Nile virus. But when that is seen, that helps differentiate and separate between the two. And that would be a reason to contemplate getting the IgM test for West Nile virus at that point.
Okay.
And the second presentation, which is regarding the bilateral uveitis and the vasculitis clinical case. And we have a questions with any questions regarding this clinical case presentation?
Wonderful presentation, really well done. How common is bilateral or is intermediate uveitis in Armenia? I don't recall it being a particularly common issue there.
It is in average aged people, and we cannot recognize any reason. It is mostly idiopathic as it is represented in the literature, and most percent of the cases, around 70% of cases, it is idiopathic, and it is happening in average aged women. In Malayan ophthalmological inflammatory department, we commonly see these patients. And of course, we have the manifestations without the retina changes, only in the vitreous part changes.
Is
Mai
it common
clinică
in
de
Armenia as opposed to other countries?
I don't have, so unfortunately, that much experience, as much as we can see in our clinic and in our department. We see these patients very, very commonly. Let me add that in different types of the uveitis are happening. In uveitis and the primary uveitis. And it is interesting that this uveitis, which was represented, it is going to the vasculitis. It is true, it might happen. But when we are following the patients as a vasculitis and the inflammatory cells are added, were added in a few months later, and we changed and it was interesting for us, and we decided to represent this to you, this clinical case. And I think, and do you see commonly this kind of patients in United States?
Barry, why don't you answer that and then you can pose your question.
Sure. We don't see it commonly, but we certainly see it. It's, and typically in young women, there's a spectrum of conditions. But actually, I had a question for Armin. In the early manifestation, one thing that is common in Armenia is Behçet's disease. Is there an intersection overlap in the early manifestations of Behçet's disease with this Irvan-like syndrome?
No, it's very, very seldom.
Very similar. Thank you. I was imagining in Armenia that the initial thought was was there initial thought that this might be Behçet's disease before you switched the diagnosis, or what was the diagnostic process for this case as it presented itself?
Yeah, maybe.
The third presentation, which was done, there was a clinical case, the connection between preeclampsia and ischemic retinopathy. And this case was very, very interesting clinical case. As we see very, very few cases like this, they are rare. And this case happened in July, and you can see how hard it was for us to have some improvement. And the treatment, there's also treatment in preeclampsia, and they continued to reduce the symptoms, but in this case it lasted long. From July we were treating this patient, until now we were treating the patient, and unfortunately we cannot relieve all the issues of this patient. And we thought that this might be a case in both eyes. It might be in both cases in preeclampsia. And this acute continuation was going back very, very badly. Like 4 or 5 months it was lasted, and it seems to be like a chronic process, which is not common for preeclampsia patients, changes. And in your practice, what can you tell us? Do you have a lot of clinical cases like this, and what are your treatment approaches in these cases? What will suggest for the follow-up and for the treatment of these patients if the symptoms are not improved after treatment of preeclampsia? Now, she already has delivered her child. There is no preeclampsia, but the pathological changes in the eyes are still there, and they are not responding to the treatment that much better. Only for the treatment, we also added anti-VEGF injections, as we can see that it lasts longer, and so to avoid the neurovascular changes, so we did these injections. How do you think, what else can be done? And how this diagnosis is possible for you? You see these patients, and how will you follow up these patients?
So again, it was a challenging case. Preeclampsia is still a challenging condition. We do see it occasionally, though not typically in the United States. It does happen. And again, it tends to happen in younger mothers as well. So occasionally we see it in those. But I agree that the management is typically anti-VEGF for the neovascular edema or edema, that neovascularization, or if there's macular edema. But all you can do is continue to monitor that. If there are pigmentary changes, those can result in permanent visual loss. A consideration after the preeclampsia is over is local steroids as well to consider to see if that will help if the anti-VEGF agents have not helped. So that's another consideration. I see that Dr. Peng Yan has joined us. We had a couple questions for you, Peng,
Yeah.
about any overlap in your case of West Nile virus in the early going. I assume that ocular histoplasmosis is common in your area. We certainly see it a lot in the middle of the United States. How much
Yeah,
do
we
they look in the early going, those punched out lesions? Of course, there's the triad of ocular histoplasmosis, but but those punched out lesions look to me somewhat similar to the West Nile virus. What is your thoughts about that?
Yeah, they can be, because the thing is, when they present in the beginning, they can present with anterior uveitis.
Right.
Usually they're very mild vitritis, where toxo can present with more intense
Not
vitritis.
toxo, histo.
Histo, yes, the histo spots, yes.
That's what
Histo,
I'm referring
we
to. Yep.
yeah, we probably only see around the Ottawa region. So yes, that's right. So in the beginning, they definitely certainly can be, and over time, those histo spot, yeah, those are also the mimickers, right? The histo spot, the PIC, the MCPs, you can definitely be fooled by it. And that's why the constellation of the viral prodromes, the findings of these lesions, there's just a little bit more of them. But I mean, that's your clinical suspicion. Is there like a definitive early diagnosis of it? Probably not. You just have to, based on IVFA, OCT, and your clinical judgment and the story that the patient put together.
And how much, the other question I asked is how much to me, one of the things that defines it to a certain extent, though it doesn't always occur, but when it does occur, is that chain of pearls effect on FA that you can see. Is that what would precipitate the getting a immunoglobulin and IgM test for West Nile virus? At what point would you, if assuming that they're asymptomatic from a prodromic standpoint, from a systemic standpoint, at what point would you initiate the IgM test for West Nile virus?
Probably very low, because I mean, for many of the patients that we see here, the thing is, we're probably sometimes can be the first to diagnose the condition, because it might have like a viral mild symptoms, and internal medicine actually work of the patients. They were hospitalized for weeks, and someone clever enough said, why don't we do a West Nile IgM? Because it's just not something we don't see, and that's why it's so important to raise awareness of it. You can just miss it, right? And then in the community, God knows how many more patients there are. It's just underreported, because if they're mild, why would you do IgM West Nile?
It was a great case you showed. Now they're asking, we're talking about the preeclampsia case. Any thoughts about what persistent vision or managing preeclampsia after the pregnancy is over and there's still some manifestations of disease? What is your approach?
It depends. I think majority of patients can actually do pretty well.
Right.
But some, if you truly ask them to check between their good eye and the eye that had preeclampsia or hypertensive, so crisis in that eye, they will always say that eye is not the same. Of course, every time we check visual acuity, they can still see pretty good, but our vision's more than visual acuity. Their contrast sensitivity, the way they see things is different, but for sure there will be some damage.
And any thoughts about how you would manage the longer term damage? Do you ever try steroids for the long term, local steroids for the long term damage if anti-VEGF is not helping? At what point would you consider other options versus observation?
Yeah, so I do. So anti-VEGF is, I'm assuming, if anti-VEGF doesn't work, steroid is a great option, because many of the vascular diseases are actually going to convert into a more sort of inflammatory cascade.
Right.
So for example, even some RVOs, DMEs, these all have inflammatory component. So if anti-VEGF doesn't work, your best bet, subtenon Kenalog, intravitreal, triancins, Ozurdex, these are all great options to try.
Perfect.
Of course, you watch out for cataracts and pressure and all that.
Right. So that was Armin's question, Vardanian. So Armin, again, consider the possibility of steroids in this patient who still has some symptoms after anti-VEGF as a consideration.
Hey, thank you.
I have one more question from online. In the patients in whom the preeclampsia is developed, and then there's an eclampsia development, and the patient's condition is worsening, they stop the pregnancy, and they do the abortion, and so to improve the patient's condition, and then decrease to have the reversion of this increasing of the blood pressure. And I was asked a question: how do we think, in case of these changes which are happening in pregnancy, is it necessary to interrupt the pregnancy? And I would like to say that to this question that generally, in case of the preeclampsia patients, the process is happening very, very quickly. And one of main advantages from the chronic hypertensive retinopathies is there is no damage in the pigmental epithelium. So as soon as there's a delivery and the process is stopped, and the recovery can happen very, very fastly. The vision also, and the cells are not damaged in the retina. But in our case, the process lasted longer, which is causing some worries in us, but the vision is gradually recovering. And as the process is good into both eyes, it is recovering. We have some worries that during this regeneration processes, the neovascularization or something new will not happen. And yes, hormonal therapy will be very, very useful. We have no doubts with this, because the hormonal treatment with anti-VEGF and anti-complement, they have an anti-complementary effect as well. But at the same time, we are a little bit sure that this anti-VEGF therapy which is performed, we are not injecting the hormones intravitreally. And I cannot tell you why, but we are always we are very, very careful with the usage of the hormones. This anti-VEGF therapy, when there's a macular degeneration, because anti-VEGF drug usage, we do not increase the risks in immunosuppression of the patients and increasing the pressure and other complications. And there's a steroidal cataract, which is not that much commonly happening, but we try to avoid this. Is it about the intravitreal injection or generally administration?
Intravitreal is what, or subtenons is what I'd recommend for the steroid use.
Yeah, steroids. Yeah.
Yeah.
I have a comment. I think, in terms of assessing the severity of damage. I mean, doing an IVFA or doing an OCT angiography, you can see the extent of the damage, the vascular damage, the areas of non-perfusion. Then, depends on how poorly it is. I mean, sometimes you might have to supplement some laser and to reduce the VEGF load. And if the vessels are diffusely leaking, then really your options are VEGF or steroid to sort of help with the vascular integrity. Otherwise, the rest is just whether or not the patients, if young enough, they might recover some, but it depends on the initial sort of the injury, the insult.
Agree. And with the other question, the other part of the question, Armin, I don't know of any case where the vision drove a decision for an abortion. It's really saving the mother's life. This is a lot, any abortion concept here is really more driven on survival of the mother, not the vision so much. So vision is what it is, and we deal with the consequences. And of course, we don't give anti-VEGF injections to a pregnant woman either. So you can give steroid injections to a pregnant woman in the eye. So that's one thing during the active phase to consider, but it's really the management postpartum. If presumably the mother survives, and hopefully the fetus survives as well, but it's a challenging condition, and again driven more by the survival of the mother as the goal, not necessarily vision.
Is Dr. Cooperman, you brought up a good point. So so the thing is there's a concern about anti-VEGF injections in pregnancy. But the counter argument is we're actually giving injection to fetuses for ROP. In those cases, I mean, and they also do fine. Of course, there's always a concern that giving anti-VEGF or any treatment during pregnancy, if anything happens, that might be a problem. But realistically, I mean, I think in some cases, if you have to, and the mother agrees and they understand, I think the risk is still fairly low. Do you agree with that? Where you think, that's just
Well, I have a couple thoughts on that. One is that, even a premature infant is postpartum now, and so their vasculature is largely intact. When the earlier the pregnancy, the more risk there is from an anti-VEGF injection. Now, I'm sure that all the Western retina and everybody who's given many, many, many anti-VEGF injections has inadvertently given it to a pregnant woman. We don't always know, and we're not aware of much risk, but I don't know of a real protocol to willingly and knowingly giving in an anti-VEGF injection to a pregnant woman. So I would still avoid that. Typically, it's more common. The management is really more of diabetic retinopathy. That's what we see all the time. And so young women who are pregnant that develop diabetic macular edema, how do you manage that? And to me, that's either intravitreal steroids, observation until postpartum, and then anti-VEGF postpartum.
I would like to make one amendment that as we did the anti-VEGF injections after delivery, when the patient already delivered the child, and after the preeclampsia was resolved, and in the fundus we have not positive changes. That's why we started the anti-VEGF drugs. And we also do not do the injections of anti-VEGFs during the pregnancy. We never inject them in pregnancy.
Agree.
I would like to say thank you to our mentors. And we would like to mention the presence of the Dr. Cooperman and in Armenian eye care project, our long-term mentor and Dr. Cooperman. It was very, very nice to see our new colleagues. We have a small thing. We also should answer the question to the test. So we have the pre-test and the post-test. And so we would like to ask to show the questions.
Great presentations. Thank you for the invitation. And it's been a pleasure being here. Be well, everybody. Happy holidays.
Thank you very much for your
Good to see you, Armin.
participation.
Good to see you all. Thank you. It's always a pleasure. Say hi to your family.
Okay.
Cheers. Bye-bye.
Thank you. Thank you. Thank you.
Bye-bye.
Bye.
Thanks.
Thank you very much for having me.
Oh, thank you. Hopefully, we'll have more of such meetings. And maybe one day you will decide to come to Armenia with Carmen.
Oh yeah, I will for sure, 100%. I'll try to make it up for getting in and out. I'll talk about more about surgical stuff, and because uveitis is Dr. Cooper, I didn't realize he was here. I wouldn't have presented West Nile. Too dangerous. He'll call me out on all this.
But you did well. Don't worry.
Thank you.
Thanks, everyone.
Thank you very much.
Thank you. Thank you.
It was very
Thank you.
interesting presentation, Carmen. Thank you so much.